Hi everyone, I'm Ali Yılmaz. I'm a pediatric radiologist at McMaster Children's Hospital, and I'm going to talk about necrotizing enterocolitis in this lecture. Despite advances, the etiology is still unclear. It primarily affects premature infants, and it's the most common cause of acute abdomen in the neonate, and the major cause of gastrointestinal morbidity and mortality. The frequency is increased every day, and the most common location is terminal ileum. I am showing you this picture to show you uh, what we are dealing with. We are dealing with very tiny preterm infants. And look at that. Look at the size of the hand and the baby. It's 600 grams. It's very tiny. The bowel is very tiny. So we are imaging a very small organ in the neonate. And they are very vulnerable. And this is a healthy bowel, and this is necrotizing enterocolitis. It's a necrotizing pathology, but it's not same as the necrotizing bowel ischemia in the adults. There is also some inflammation. It's a different entity, and there is no occlusion of the major vessels. The incidence is 3 to 11%, and mortality is very high, actually 20%, depending on the management of the patient. In this slide, I tried to summarize the process here for someone who is not familiar. So we have the premature infant in the NICU. We're always talking about prematures, but matures can also develop neck. Usually in the first 3 days, we don't see neck. If you see a necrotizing enterocolitis in the first 3 days, most likely it's a mature infant, not premature. It's there's a reverse correlation with the age. So we start the feeds in the premature infant, and GI symptoms occur, and then the neonatologist uh, does these tests in addition to physical examination, some laboratory tests and x-rays, and confirms the diagnosis of necrotizing enterocolitis, and the treatment is stopping the feeds and starting TPN and antibiotics. Then a dynamic follow-up process starts with x-rays. It can be very dynamic. It can be daily x-rays or even every 6 hours to detect perforation, depending on the severity of the disease. And we can also add ultrasound in selected cases here. If a perforation is detected, and this is based on demonstration of pneumoperitoneum on the x-rays, the patient goes to surgery. If the symptoms resolve and we confirm resolution, then feeds restart. And now we are back to the beginning. The symptoms may reoccur, the neck can come back, and then we are going to follow the same steps again. We also need to learn about the Bell classification of necrotizing enterocolitis. As radiologists, we don't have to know this table, but we need to know that the diagnosis of neck is a spectrum. In the early stages, there's suspect neck, there's proven neck, and then advanced neck, depending on the stage. And in this one, as you can see, there are some clinical findings for the decision. And this is also associated with some physical examination findings and also X-ray findings. So for example, in this one, in the very early stages, stage 1, the radiographic findings are normal. So a patient can have a suspect neck with a normal abdominal radiograph. But then in the advanced disease, we see, like in the stage 3B, we see free air. So this is confirmed advanced stage. So as you can see, there is a spectrum, and radiographic findings are not decision maker for the diagnosis. Diagnosis of neck is based on clinical, laboratory, and radiographic findings. So what do on the X-ray? X-ray is the main horse. We have three views: AP supine, lateral supine, which is also called cross table, and AP lateral decubitus views, usually on the left side. And we do this routinely, and if we have a suspicion of perforation, we add either of these two. This is easier for the technologists, so they don't have to position the patient, and it's easier. But if you can do this, this is also an option. Let me show you normal findings on the abdominal radiograph in newborns. So as you can see here, in the early hours of life, we see partial aeration of the bowel loop starting from the jejunum in the left upper quadrant. This is normal in the early hours of life. By the end of the 24 hours, the gas reaches to the rectum. We don't expect dilatation of the bowel loops. We see this mosaic pattern, and there's usually this mass effect in the pelvis, which is the bladder, and this is a normal finding. And there's always life supporting lines and the umbilical sutures, as you can see here. Because of the umbilical lines, you can see a clamp, and you can see the ECG leads over the patient, and the feeding tube, the UVC. Here is the UAC, and a lot of lines. And these are all normal features. This is what we expect in a normal baby. And this is the mosaic pattern. This is mosaic, and we don't expect dilatation of the bowel loops. I summarized the main radiographic findings of neck in this slide. We can see a loss of mosaic pattern, elongation, separation, gasless abdomen, fixed loop, asymmetric bowel gas pattern, pneumatosis intestinalis, portal venous gas, nova peritoneum, and a distended abdomen. Let's see them one by one in detail. This is normal for comparison, and this is loss of polygonal configuration. As you can see here, we don't see the normal mosaic pattern anymore. Some loops are dilated, there's some separation, and there is no uniform caliber of the bowel loops throughout the abdomen. Another finding is dilatation and elongation. We usually assess the dilatation visually. We don't quantify it. This is normal, this is dilatation, and dilatation is usually associated with elongation. In normal bowel loop, because of the normal peristalsis, we don't expect to see a long segment of the bowel in one projection like this. It's usually associated with dilatation. And as you can see, mild and a more severe dilatation. In some cases, it may be difficult to assess the dilatation. Is there dilatation or not in between these two, for example? In these cases, I recommend you to look at the lateral views. Lateral views are usually easier to assess the dilatation and distension. So if there is distension in the abdomen, you can easily assess, which is on the lateral views, which is not possible on the frontal projections. This is a normal abdomen, and this is a mild distension, and this is a severe distension, as you can see here. Here in this one, it's mild, so lateral view is helpful. There is also paucity of bowel gas, also called gasless abdomen. It doesn't have to be completely gasless, but when there's paucity of gas, it's called gasless abdomen. For example, in this patient, initially the bowel loops were normal, then the patient developed neck. Usually it's seen in the advanced stages when there's perforation or peritonitis. And in these cases, the ultrasound is more helpful because there's not much gas. Another finding is asymmetric bowel gas pattern. The distribution of the bowel loops should be uniform in the abdomen, as here in all quadrants. But here we see less bowel gas in the right hemiabdomen compared to left. Separation of the bowel loops is another finding, as you can see here. There is normally some separation, as you can see here, because of the normal bowel wall thickness. But in these cases, it's a little bit more than the normal. The separation can be secondary to bowel wall thickening or can be secondary to ascites, and the latter is actually more common than bowel wall thickening. Another finding is, again, a separation and bowel wall thickening. We can also see it as thumb printing pattern. It's more pronounced form of dilatation and separation. As you can see here, thumb printing pattern. Assessment of fixed loop depends on review of serial radiographs. Normally, due to the physiologic peristalsis, we don't expect to see the same loop of bowel in the same position and same configuration. Here you can see serial radiographs daily in the same patient, and if you choose one loop, for example this loop in the right upper quadrant U-shaped, the next day it is still in the same position, same configuration, third day, fourth day, fifth day, sixth day. So this is a fixed loop and it's a sign of necrotizing enterocolitis, and it shows that there's lost peristalsis. And here, this is a very cardinal sign of necrotizing enterocolitis. We usually look for this to confirm the diagnosis, pneumatosis intestinalis. It is intramural gas, but the wall actually has the mucosa, submucosa, and even serosa. So there are multiple layers of the wall. So the gas can be within the inner wall, within the outer wall, or in between. As you can see here, it usually affects long segments of bowel, as you can see here. One of the things that we need to consider is we are always looking for gas on the in the wall, but here, so this is gas in the wall of the bowel, but if you think three-dimensional, the gas in the wall will appear like this in other projections. So don't always expect to see this, but if you see gas even in the lumen of the bowel, this gas can be in the wall of the in the distant wall. Not, it doesn't have to be in the lumen. This is one thing to consider. For example, here we see gas in the wall, but also gas in the lumen. But this lumen, this is actually not lumen. This is the distant wall or the closer wall. Try to think three-dimensionally. And for example, here we see a lot of bubbles, but they are not really corresponding to the wall of the bowel, but it's actually the wall. Another case, we see gas in the lumen, projecting over the lumen, but it's actually in the wall of the rectum. Another finding of necrotizing enterocolitis is portal venous gas. It was initially considered to be an ominous finding, but nowadays we see this finding in patients with better prognosis. So it is not an ominous finding. As you can see here, it's not a sign of perforation. Here you can see local branching gas projecting over the liver. Pneumoperitoneum could be the most important finding in necrotizing enterocolitis, as it's an indication for surgery. It could be very difficult to assess small amount of gas on the frontal projection, but it's much easier on the lateral projections or on the decubitus views, as you can see here. The air will be seen on the non-dependent aspect of the abdomen, just beneath the anterior abdominal wall. Another Another example of pneumoperitoneum, as you can see here, there is extensive pneumatosis intestinalis. It's not clear if there's free air or not, but on the decubitus view, as you can see here, as crescent-shaped free air, and this confirms intestinal perforation. If the gas is a large amount, then it will be seen over the abdomen. Very lucent, can be symmetric, and sometimes it can be missed because it's too much on the frontal projections especially, but on the lateral view it's easier to detect. Sometimes because of the falciform ligament here, very echogenic and projecting over the liver, this is called football sign. And these were the radiographic findings of necrotizing enterocolitis. But NEC is not all about radiographs. Ultrasound with Doppler can be problem solving. So let's see what we can see on the ultrasound. This is a very nice paper, and this summarizes the stages of necrotizing enterocolitis. This is normal bowel, and in this stage there is some bowel wall thickening and hyperemia, and then there is decreased peristalsis associated with bowel wall thickening, and there's thinning of the wall, and then at this stage there's absent vascularity and perforation. This is necrosis, and it will result in perforation, but doesn't have to follow the order. Some patients present directly with perforation at this stage. On the ultrasound, if there's gas, we don't see much. If there's not much gas, we can easily see the details, small bowel loops filled with gas, as you can see here, ileocecal junction here, and some small bowel loops, some normal vascularity, colon can be seen like this. So ultrasound can show the bowel very nicely. Doppler is especially helpful. As you can see here in the healthy babies, we can assess the flow with color Doppler, with power Doppler, ADF, SMI, color, SMI monochrome. We did a research almost 6 years ago, and we found that SMI was superior to the other techniques. But as you can see here, this is normal expected vascularity. We should always see it. It confirms that the bowel is not dead. There is no necrosis. I summarized the sonographic findings of NEC in this slide. So this is the normal bowel. We can see bowel wall thickening. We can see hyperemia or decreased vascularity. It will be less than this. And absent flow here. And we can see decreased peristalsis. It's an observation of the sonographer. And pneumatosis intestinalis, just like the X-ray. We can see portal venous gas, just like X-ray. And we can see complex fluid collection, as you can see here. Let's look at them one by one. As you can see here, there's gasless abdomen, which is very good for ultrasound, so we can nicely see the bowel loops. Here, there is some bowel wall thickening and hyperemia. When you see this Y-shaped or complete encasement of the bowel with flow, then it is a sign of hyperemia. You can see mild hyperemia here. We normally don't expect to see these parallel lines, long segments of bowel in one single image like this. And this is marked hyperemia, as you can see, circumferential color coding around the loop. And this is marked hyperemia. When we see absent flow, it's a sign that the bowel is dead. There is necrosis, and then it's irreversible. So the patient will eventually develop perforation, and sepsis. So these patients need surgery. As you can see here, in this one, on the X-rays, there was no pneumoperitoneum, so there was no perforation, but on the ultrasound, we see some pneumatosis intestinalis, as well as no flow in the colon. So the patient underwent surgery and the colon was completely dead. As you can see here, this is appendix, this is cecum. It was resected. It appears white. White color represents necrosis in the colon, just like this. So it is an additional finding for surgery to X-ray, absent flow, that you cannot see this on the X-rays. So to repeat, perforation and bowel necrosis are two main indications for surgery. Bowel wall thickening, it's here in the papers, and in my paper, it is 2.6 millimeter. Over 2.6 millimeter is thickened, but I think it's too much. We usually don't measure it. If you believe that it's thickened, as in this case, it's thickened. If you measure this could be less than 2.6 millimeter, but it doesn't matter. As you can see here, there's bowel wall thickening and some fluid around it. When the fluid is simple, it doesn't have to be perforation, but when it's complex, as you can see here in this patient, perforation with feculent contamination, this was a complex fluid collection. It's a sign of perforation. Decreased peristalsis is operator dependent, and your technologist should be telling you about this, but I tried to show you. Normally, we see some peristalsis, but in these cases, there is no peristalsis. Another one, this is normal peristaltic bowel, but this is a patient with necrotizing enterocolitis, some bowel wall thickening, some free fluid, and the bowel is not moving. Pneumatosis intestinalis or intramural gas can be seen on the ultrasound. The gas can be within the mucosa, submucosa, in the wall or outer serosal component of the wall. See here, I will show you some other examples of pneumatosis intestinalis. On the X-ray, we are not completely sure if there is pneumatosis or not, but ultrasound confirms intramural gas in this patient. On the ultrasound, very mild thickening and intramural gas, as you can see here. And there's also some gas intraluminal and submucosal here. There's mild hyperemia. Here you can see the mucosa and submucosa. So the gas can be all the way from submucosa to the serosa, and that's why we see some gas, some foci of gas projecting over the lumen, some in the wall and some in the outer wall, almost outside of the bowel. As you can see here on the histopathologic specimen, the gas in the wall, and here we see tiny foci of gas in the wall, which is thickened. We can also see portal venous gas. Portal venous gas is usually in the periphery. P, portal, periphery. And here, multiple foci, and there is also intramural gas in this patient. We can dynamically see the portal venous gas, as you can see in two different patients here, in the main portal vein and some clusters of gas in the liver, as you can see here, branching portal venous gas. This could be a temporary finding. You can see this, and they may disappear on the follow-up ultrasound, which you do in 2 hours. So, and this doesn't have to be associated with bowel necrosis or perforation. Finally, I would like to mention about sequelae of neck, colonic stricture. So in some patients who survive necrotizing enterocolitis, uh, the necrosis can be healed with stricture. And we can see them on the colon. These patients present with bowel obstruction. And here in this patient, initially was normal, then developed necrotizing enterocolitis. You can see pneumatosis intestinalis, bowel dilatation. Then the patient was treated and survived, and then developed obstruction again. And when we did the enema study, we can see this long segment stricture in the transverse colon. This is a late complication of necrotizing enterocolitis. So take-home points. Diagnosis of NEC is based on clinical, laboratory, and radiographic findings. Radiographs are standard care. However, use ultrasound with Doppler when needed. Imaging is crucial not in just making the decision of surgery, but also for the decision of restart feeding. And thank you for listening.